Let's begin our next chapter, Neurocognitive Disorders. It was formerly called Dementia. Now, what is this neurocognitive disorders? These are impairment in clear consciousness. And similar to delirium, the symptoms of dementia can be caused by many separate disease processes. We will take a look at different diseases in which dementia or there's memory loss which occurs. This is usually a disease of old age. And to understand the changes related to aging and dementia, I will use the word dementia from now on over neurocognitive disorders. Let's take a look at the different age-related changes compared to dementia. When we talk about dementia, the family is more concerned about the patient and they are the ones who will bring them for evaluation. But in normal aging, the person will be concerned about the memory loss. And the recent memories are more intact in normal aging. So they will forget memories of the past compared to the more recent events. But in dementia, it is very common that the most recent events, the memories of those will be lost before the long-term memories, the memories of long ago. Then there's expressive aphasia in normal aging, but no receptive aphasia. They will be able to hear and understand properly. In dementia, you have both with word substitutions. They will replace words that they speak with weird words usually. And one of the most important things you need to know is normal aging means that they will be able to maintain independence in activities of daily living. They will be able to brush their own teeth, they will be able to get out of bed, do their normal daily activities such as doing their finances, as they usually do. And they do not get lost in familiar environments. But dementia patients, especially as we go for moderate to severe dementia patients, they become dependent on others for activities of daily living. And they can get lost for hours in familiar environments. This is the most important difference between the two. And normal aging, they can operate common appliances like the microwave. They will take some time to figure it out, but they will be able to do it. But dementia patients will be unable to do even that. And they will maintain normal social skills through normal aging. But dementia patients lose interest in all social activities. It is also important to know the difference between delirium, dementia, and depression. In our first chapter, we discussed about delirium. Some causes includes anesthesia, then urinary tract infections, then the use of anticholinergics. Now this question will be asked in USMLE Step 2. Anticholinergics in elderly can lead to delirium. And this is a condition in which there's an acute onset with impaired consciousness and the course is fluctuating. You visit the patient in the morning, he's fine, but 3 hours later, he's agitated. He uses vulgar language when speaking. He has different hallucinations, all of this. And the prognosis is reversible. You need to correct the underlying condition and the person will be fine. Memory impairment will be present during the episode. In dementia, the onset is more gradual. Consciousness is intact. But the course is progressive. Through the years, through the months, it will gradually worsen. And the prognosis in general is usually irreversible. And the recent memories are spared. Remote memories are spared. Not recent. Depression is another condition. We will talk about something called pseudo dementia. This is simply depression. And we have discussed what depression is. Onset is gradual, consciousness is intact, the course is episodic, depression is episodic, and prognosis, it's reversible. There is loss of concentration and focus. Memory is spared. The presentation of patients with neurocognitive dysfunction is there is going to be memory impairment, and there is going to be progressive disorientation. It's always going to be disorientation to time, place, and then person. There will be language issues. They will have difficulty speaking words. They will get confused with words. These patients will have impaired executive functions. Now, there are 8 executive functions commonly identified, such as self-control, self-monitoring, emotional control, flexibility, task initiation, organization, working memory, planning, and time management. We don't need to know all of these, but there's going to be impairment in those activities. Then there's going to be visuospatial impairment. This is when there is a loss of sense of where you are. The person could be in the middle of his house, but he will not be sure where he is. Apraxia is when there is an inability to perform particular purposive actions. And there will be personality changes. There will also be associated psychiatric symptoms, anxiety, depression, hallucinations. Now, hallucinations is a very common thing. There will be visual hallucinations. And in Alzheimer's disease, we will learn that there is a more severe form, a more scary form compared to Lewy body dementia. What are the causes of these neurocognitive disorders? The primary neurodegenerative disorders are Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, Prions disease, this is now called Creutzfeldt-Jacobs disease, Huntington's disease, and then there are vascular causes such as vascular dementia due to strokes, focal thalamic and basal ganglia strokes, subdural hematomas. Then there are inflammatory and autoimmune causes such as SLE, trauma. Boxers can commonly have dementia due to severe head injury. Infections and related conditions. Now, I need to give something important here. HIV and neurosyphilis are very common causes and must always be tested when testing these patients for memory impairment, for neurocognitive disorders. Then there are metabolic endocrine causes, neoplastic causes, post-radiation where there is damage to the brain after radiation. Then post-anoxia due to severe anemia when there is low oxygenation of the brain. And also the other things you need to test for in terms of medical causes are vitamin B12 deficiency and folate deficiency. Now, while we test patients for neurocognitive disorders, we need to always do an HIV neurosyphilis test. Also, you need to check the vitamin B12 and folate levels of the person. Then toxins can cause it. And we will also learn about something called normal pressure hydrocephalus. The assessment of these patients. One commonly used test that you need to know is the mini mental status examination. It ranges from 21 to 24 when it is mild neurocognitive disorder. But these patients do not have impairments in their activities of daily living. When it's moderate, between 10 to 20, they will have difficulty maneuvering themselves through a supermarket, or they will get lost easily even if they are in a familiar environment. When it's severe neurocognitive disorders, they will not be able to do any sort of activities of daily living. They will need someone to even tell them where the toothbrush is, or even help them to brush their teeth. Then we will learn about Parkinson's related dementia. All of these also needs assessment of motor and processing skills. This dementia questionnaires for mentally retarded persons and Dalton's brief praxis test to monitor changes in function. These can be done to determine the current situation of the patient. Then routine blood tests. You need to do the tests as I mentioned above, FBC, UND, vitamin B12, folate, liver function tests, and also tests for HIV, syphilis, serology. In terms of radiology, we don't really do it unless we need to confirm a diagnosis of vascular dementia or something which will present very clearly on CT or MRI. Lumbar puncture. This is done in normal pressure hydrocephalus and Prions disease. Then genetic tests for familial dementia, such as Huntington's chorea. If the person presents with Huntington's chorea, we will be doing a genetic test to see if the person has Huntington's disease. Brain biopsy and EEG for Prions disease. There is a very characteristic finding here, which I will explain. And then we can do cerebral blood flow test to see if there is vascular dementia. Now, when we talk about Alzheimer's dementia, this is a more generalized topic, Alzheimer's disease, dementia. The other subtypes will usually branch out from this. So if you can understand the clinical features of Alzheimer's dementia, those same clinical features will be present in the other types, but there are some distinct differences. So before we go into Alzheimer's dementia, let's go into those distinct differences first. Now, I made this table to help you in the exams to differentiate between the different types. I only put the most high yield differentiating points in this table. In Alzheimer's dementia, it is more common in females. And usually there are scary visual hallucinations with late personality changes. Okay, when we talk about the scary visual hallucinations, what this means is they would cause the patient to call the police. The person would see an animal, a lion in the garden, or the person would see thieves breaking into the house. This would scare the patient, and the patient would call the cops. The cops come. There's no one around. And when the patient does it for the third or the fourth time, they will take the patient to a psychiatrist. This is very common, and this happens. This is something you need to differentiate against Lewy body dementia. The hallucinations there are not scary. These people will see, let's say, an animal on the floor. Even though there's no animal there, they will see a cat on the floor, or they would see people around. Another thing that you need to know is this Alzheimer's dementia is a very slow progressive disease. It starts very slowly. So the patients will not know exactly when the symptoms started appearing. And to help them to function normally, they would lie and confabulate. When they have lapses in their memory, instead of figuring out there's something wrong, they would lie and confabulate. This is normal in most people. But there's another subtype, which I talked about earlier, pseudo dementia. This is basically depression. And these people would know the exact moment in time when the symptoms started. So compared to Alzheimer's dementia, pseudo dementia patients will know the exact moment in which the symptoms started. And also, Alzheimer's disease patients are usually taken by others to get help. But pseudo dementia patients, they want help. And the treatment for them is antidepressants, because this is just depression. And also, it's important to know that Alzheimer's dementia is associated with Down syndrome, because there's a trisomy of chromosome 21, there's a 3 pairs of genes. Next, let's take a look at vascular dementia. This is more common in males, and there are focal neurological deficits, such as a paralysis of the leg. And the onset, usually this is of an acute onset with stepwise decline. So when you do an MRI, there will be multiple infarcts seen in the MRI. When we talk about Prions disease, there's going to be a lot of behavioral changes, myoclonus, and seizures. And what's important to know is the onset of this disease is very rapid. It has the fastest progression, and the patient will usually die within 1 year. And there's a characteristic EEG finding on Prions disease. This is called the triphasic waves on EEG. This fact is very important to know. Next, when we take a look at frontotemporal dementia, there's going to be personality and behavioral changes. And most commonly, there will be disinhibition. So this is basically when people act in a socially inacceptable way. This is called disinhibition. And these patients, what this means is, they will be likely to, when someone comes to your house, you would be likely to just open the door, see the person who has come, and shut the door without even talking to them. And there are a lot of cases in which these patients would sexually abuse people around them for no reason. Then there's Hypo Orality, in which they have increased need for eating. We will talk about this in more detail. What I need you to understand in frontotemporal dementia is it's a bit more early onset than Alzheimer's dementia. But compared to Alzheimer's dementia, in which you get global atrophy, that is, the brain will atrophy in a more global way. The entire brain atrophies. That makes the ventricles look larger. But frontotemporal dementia, from the name you can understand, it's the frontal and the temporal lobes that atrophy. And this condition is associated with Kluver-Bucy syndrome. Next, Huntington's disease. This is not going to be discussed as its own topic here because this is more of a medical topic. There's going to be choreoathetosis, Huntington's chorea. They would have movements, flinging of their arms, this type of movements. Then there's going to be dementia, and there's going to be psychosis. Now, it's also important to know that these patients, they will have these symptoms developing over a long period of times, sometimes 15 to 20 years. So there would be tremors, all of these, which develop over time. And these patients would have seen a family member go through this disease. They would have seen them become gradually worse and then die. So there is a very high risk of suicide in these patients. There is caudate lobe atrophy in these patients' brain scans. When we talk about HIV dementia, you need to understand this is only seen in untreated HIV patients. If the patient does not have, if the patient's viral load is not being treated, then this is going to be HIV dementia. We will talk about some cases, and you need to look for HIV risk factors such as sharing needles, unprotected sex, all of these. These patients will have apathy, early impairment in attention, subcortical motor symptoms. But the main thing you need to look for is their HIV load. We will talk more about this later. Then there is normal pressure hydrocephalus. In this case, there's dementia, urinary incontinence, and gait apraxia. They will have problems with their gait, urinary incontinence, and dementia. And ataxia occurs early in the disease. And there's going to be enlarged ventricles. This is going to be the typical finding with normal pressure. That's the name. The treatment is a shunt placement. Note that in normal pressure hydrocephalus, when you do a high volume lumbar puncture, there's going to be a rapid response in terms of symptom relief. When we talk about Lewy body dementia, this is when there is a Parkinson patient who also has visual hallucinations that are not scary, and dementia which start around the same time. The Parkinson's syndrome, the Parkinson's symptoms, and dementia must start together. Compare that with Parkinson's dementia. In Parkinson's dementia, the Parkinson's symptom starts first. Then after about 1 year, you get cognitive impairment. This is the way you diagnose between Lewy body dementia and Parkinson's dementia. They will have visual hallucinations that are not scary, as I explained earlier. And because of the Parkinsonism symptoms, there is going to be early falls, fluctuating cognition, and REM disorders. In their sleep, there will be REM disorders. And there's a very important thing to know here. These patients have severe sensitivity to antipsychotics. We do not give these patients antipsychotics to treat the visual hallucinations. We will go into more detail of that. And for Prions disease, I need to add, there's an association between eating mad cow disease, cows who were infected with mad cow disease, and from corneal transplants. Now that we know a bit about the different types and how to identify them, let's talk about each of these separately. First is Alzheimer's dementia. This occurs in the 60s and the 70s. When a person is in their 60s and their 70s. Patients have mild to moderate global brain atrophy with initial neuronal loss in the parietal and temporal lobes, not very important. They have global brain atrophy. And then the findings of Alzheimer's dementia. There's going to be amyloid plaques and then neurofibrillary tangles with phosphorylated tau proteins. Prominent memory impairment with visual hallucinations that would scare the patient. Exact point of symptom onset is unknown because they will lie to fill the gaps in memory. And then due to the trisomy of the APP gene in chromosome 21, Down syndrome patients are more predisposed than others. And also this is associated with apolipoprotein A4. The clinical features of Alzheimer's that we discuss is going to be common to the other neurocognitive disorders too. So, amnesia. Recent memories are lost before remote memories. Then other cognitive impairments, visual spatial difficulties. They will not know where they are. There's going to be a lot of wandering and getting lost. They will have difficulty with calculations and cognitive planning. Then there's going to be functional impairment. This means that these patients will not be able to do activities of daily living. If you have watched the TV show Money Heist, in the first and the second season, the inspector's mother is suffering from Alzheimer's dementia. She needs all these cue cards to help her function normally. She's able to read, so she would go through these cards to know what to do when in different types of scenarios. Next, mood. Depression can be confused with dementia. And dementia, pseudo dementia, can be confused with Alzheimer's dementia. So we need to know how to differentiate them. We will talk about that in a while. So we need to always evaluate the person's mood to see if they have disturbed sleep, all the mood symptoms, poor appetite, all of those. Psychosis occurs in most patients, and we talked a bit about that. There's going to be delusions, hallucinations, all of these. And there's always going to be personality changes, especially in the later stages. The way the family would describe these people is, they are a living bereavement where the person remains, but the person they once knew has long gone. How do we manage these patients? Once we know a person with Alzheimer's disease, we need to tell the family that this is a progressive brain disease that is not curable. And the family has to adjust to this patient. There will be more impairments that will be found. We need to minimize risks. Now, these patients are at high risk of falls, starting fires. They can set off a kettle, and they would forget that they started the kettle. And after, let's say 20 minutes or 30 minutes, and when the water has all evaporated, it will start burning, and they're more prone to accidents. So we need to make sure that we don't let them handle all of these. Then reorientation protocols, such as you give the cue cards that we saw in Money Heist, then good lighting, walking steps, urinals if the toilet is somewhere far away, because there's a type in which the patient would just, we talked about disinhibition. So it is very common that these patients would, whenever they feel like it, they would just pee wherever they are. Memory aids, such as using large calendars. And also you need to keep the doors and the gates closed so that they don't wander off. Now, when we think of pharmacological treatment, the main treatment is to make sure that the acetylcholine levels remain elevated, because it has been found that acetylcholine is related to memory. And the drugs we usually use for Alzheimer's patients or for memory loss are donepezil. This reduces breakdown of acetylcholine. Rivastigmine, galantamine, these are acetylcholine esterase inhibitors. And then there's a glutamate increasing drug called memantine. And then we can give antioxidants, because oxidants can damage the nerves, causing all these memory impairments, such as vitamin E, D, and B. Next, vascular dementia. This is dementia with a cerebrovascular disease. So when you do an MRI, there will be a lot of focal deficits. Let's take a look at a case of vascular dementia. An 85-year-old man with a history of hypertension and cerebrovascular accident is admitted to the hospital due to a recently diagnosed arrhythmia. Neurological examination reveals right leg paresthesia. His wife is concerned about his deterioration of mental function during the past year. He has increasingly begun to forget simple things, including how to walk home from the top of the road. So the patient has dementia, focal neurological disturbances, and a history of hypertension and cerebrovascular diseases. Next, we have frontotemporal dementia, and this occurs mostly in patients in their 50s and 60s. There's going to be degeneration of the prefrontal cortex and the anterior temporal lobes. That's the main difference between Alzheimer's dementia and frontotemporal dementia. There's going to be phosphorylated tau proteins and an abnormal TDP43. This is also found in ALS patients. Amyotrophic lateral sclerosis patients will also have this finding. Now, these patients are characterized by poor executive functioning, then disinhibition. Here are some examples. Hypo Orality. They will have an increased diet and a preference for sweets. This is very typical. Then they will eat non-food substances, and they might have binging behavior. Then they will have compulsive behaviors, such as repetitive speech, motion, and hoarding behavior. This is a very severe form of, a more complex form of compulsive behaviors, where the obsession is that anxiety of not losing things, not throwing things out. And the compulsion is the hoarding behavior. Next, we have dementia with Lewy bodies. Dementia with two or more of the following features. Usually the Parkinsonism, and the treatment for that is the carbidopa-levodopa combination. Then visual hallucinations, cognitive impairment, we talked about the drugs for this, and REM sleep disorders. The treatment for this is melatonin. We will talk about REM sleep disorders in a later chapter. And it is very important to know this point. In general, we do not give patients who have neurocognitive disturbances antipsychotic medications. If there is functionally impairing visual hallucinations or delusions, we must prescribe it with caution, because there is hypersensitivity to these antipsychotics, especially the older generations. Okay, we never give first generation, but the high potency ones of the second generation also have this effect. So if we have to give them, we go on a trial. With something which is of low potency, second generation low potencies, such as quetiapine. This fact must be known. Again, let me repeat this. We do not usually give antipsychotic medications for patients who have memory impairment, because this can worsen any sort of brain injuries. Next, we have Creutzfeldt-Jakob disease. This is due to the transmission of an abnormally folded protein, which are called prions, due to ingestion of mad cow, that is, cows who were infected with this prion, or corneal transplant. These are the two most common examples. There's going to be rapidly progressive dementia, ataxia, because it hits the cerebellum, myoclonus, and the word rapidly is very important here. And these patients are easily provoked so one way you can test these patients who come with rapidly progressive dementia, then ataxia. And one way you can test these patients is you suddenly close the door, you bang the door shut. There will be a sudden myoclonus movement. Then there would be upper motor neuron signs such as increased reflexes, extrapyramidal signs such as hypokinesia, and mood and sleep disturbances. When we do a CSF analysis, there's going to be an elevated 14-3-3 protein titer. Now, this is the main test that we do. Even though it's not specific for CJD, it is a marker of neuronal cell death. Along with the other symptoms, we can usually come for the diagnosis. Then there's going to be elevated tau proteins. We see this in Alzheimer's, Lewy body dementia. And then there's another test called real-time quaking-induced conversion, RTQUIC, which can isolate the prion proteins. This test is done in specific places only. Not every location has this type of facility. This is a newer test, and this is the only specific test we have right now. MRIs will show widespread atrophy of the cerebrum, cerebellum, and then cortical enhancement and enhancement of the putamen and caudate head. It's called the hockey stick sign. This is irreversible. All patients will die within a year. Now, pseudo dementia and dementia. Pseudo dementia is simply depression. Dementia is of a gradual onset. Pseudo dementia is of a sudden onset. What does this mean? The patient knows exactly when the symptoms started. And also, when the patient doesn't know an answer, they would respond with, I don't know. But these people with dementia, such as Alzheimer's dementia, they would confabulate. Recent and remote memories may be equally poor. In dementia patients they will have recent memory worse than remote memory compared to a pseudo dementia patient. And sundowning is uncommon. Dementia Sundowning is common, in which the state of confusion begins in the evening, goes till the night, and is reset in the morning. Now, this is, again, like I said, I'm making the draft for the new second edition, and this is not in the first edition. This table will be added to the second edition. We have a 47-year-old man who comes with his wife due to recent personality changes and cognitive impairment. The symptoms began 3 months ago with abrupt onset depression and profound sleepiness. Soon after, the patient had difficulty remembering names and events. He cannot care for himself and needs constant support. He has no history of psychiatric diseases, but has a history of corneal transplant 4 months ago. The symptoms began 3 months ago. The patient has a 20-year back history. Temperature is 37.7, blood pressure is normal, pulse, respiration, everything is normal. The patient is only oriented to self. The Montreal cognitive assessment score is 10 out of 30. The normal should be greater than 26. Nearer to the end of the examination, the patient startles and jerks his arm when a door closes loudly. We talked about this. The myoclonus induced when there is a sudden stimulus, when they are startled. And a lumbar puncture is recommended. Which of the following findings would be expected in this patient's cerebrospinal fluid? Now, it must be obvious that the diagnosis is Prions disease. And this is what we check for in a CSF sample. Oh yeah, I need to clarify something. Prions disease is a non-inflammatory disease. Even though we think of prions as something like a virus, it is not. It is simply a protein. So the glucose, the white blood cell levels, all of these will be normal. There's no inflammation involved. A 78-year-old woman comes to the office with her husband. The patient has a history of hypertension and hypercholesterolemia. She has no other medical problems, and today her blood pressure is elevated, and her husband says that she often forgets to take her blood pressure pills. Her husband believes that her speech has changed, as she occasionally struggles to find appropriate words and sometimes cannot recall people's names. 2 days ago, she drove to a nearby grocery store and was unable to find her way back till the husband came looking for her. Physical examination is normal. On mental status examination, the patient is calm and cooperative. She says her mood is good and scores 26 on the mini mental status examination, which is normal. Which of the following is the most specific indication of dementia? Or it's called neurocognitive disorder, as opposed to normal aging in this patient. What tells you that this is dementia and not normal aging? Getting lost in familiar territory. We all do this. This is normal. Her husband has to accompany her to the office. This is not due to dementia. Patient's awareness of forgetfulness, no. And word finding difficulty. This is normal with normal aging. Next, we have a 68-year-old man who is brought to the office by his wife due to recent changes in behavior. Despite managing the family's finances and taxes, the patient has failed to file tax returns and pay bills over the previous 15 months. He has become more withdrawn and no longer enjoys social gatherings. Check the first table, normal aging versus dementia. When he does socialize now, he's often irritable and offensive. He also now insists on eating the same thing for breakfast every morning and gets very upset if a different meal is prepared. The patient denies having any problems and seems indifferent to his wife's concerns. There is a family history of Alzheimer's disease. Blood pressure is elevated. The patient scores 24 out of 30 on the Montreal cognitive assessment. Which of the following is the most likely diagnosis in this patient? Now, it is important to know, let's look for some clues in this question. The patient no longer enjoys social gatherings. He doesn't seem to have many memory problems. Not many memory problems. But he insists on these compulsive behaviors. And it's about food. There's hypo orality. There is a change in the way the person eats food. I.e., it has to be the same thing. Also, the cognitive assessment test is relatively normal. This indicates that the patient has frontotemporal dementia. If you look back, you will see that hypoorality, compulsive behavior, and other behavioral changes such as no longer enjoying social gatherings are seen in frontotemporal dementia. Memory problems are not as bad as in Alzheimer's dementia, but over time it gets worse. These are relatively mild in frontotemporal dementia, but with age, with time, it gets worse. A 60-year-old woman is brought to the emergency department by her daughter due to loss of mobility, increasing confusion, and behavioral changes. The patient cries out for no reason and recently exclaimed that a gorilla is breaking inside. She often sees people in her room when none are present. The patient was prescribed with risperidone but had a severe reaction, causing her to stop. She has memory loss and frequently gets lost when she goes shopping in her neighborhood shop. Patient is febrile, and on physical examination she is alert but is oriented and quite agitated. If she was disoriented, delirium could also be considered. This increased muscle tone, normal reflexes, and resting tremors in the extremities. Which of the following is the most likely diagnosis? This is likely to be dementia with Lewy bodies. The reason this is dementia with Lewy bodies are the resting tremors, and she doesn't seem to be bothered by the fact that she sees people around, and also, most importantly, the patient was prescribed risperidone and had a severe reaction. This is the biggest clue you have. Next question, we have a 73-year-old man who is brought to the office by his wife for a follow-up of recent behavioral changes. The patient has been more withdrawn and sadder over the past 7 months and often appears sad. He kept getting lost several times in his neighborhood. This is an indicator for neurocognitive disorders. He now needs help with finances. His wife says he has good days and on other days appears confused. She reports that while the patient sleeps, he frequently seems to act out his dreams and has kicked her on occasion. In which stage of sleep do we have dreams? In the REM stage. So we have REM disturbances. Medical history includes hypertension and hypercholesterolemia. On neurological examination, there is bilateral resistance to passive movement of the upper extremities. And the patient walks with an unsteady gait. Montreal Cognitive Assessment Score is low, 20/30. The remainder of the examination shows no abnormalities. Which of the following is the most likely diagnosis in this patient? Now, if you refer the chart again, you will see that dementia with Lewy bodies will present with fluctuating cognition. His wife says that he has good days and on other days he appears confused. This is what you mean by fluctuating cognition. And also he has REM sleep disturbances. So the answer for this is dementia with Lewy bodies. A 76-year-old man with a 25-year history of HIV comes to the office due to worsening forgetfulness. The patient has had mild difficulty with short-term memory for the past 5 years. He often forgets recent conversations and names of familiar people. Again, this is not a sign of normal aging. The patient has had difficulty multitasking and learning new skills. This is common with age. If you give old people a cell phone, let's say a smartphone, it will be very difficult for them to learn that. Children will grasp technology really quickly, but as we grow older, our brains sort of are unable to learn new techniques, new technology. He performs most daily activities independently but requires some assistance, such as a reminder list for shopping or driving directions, even for known neighborhoods. He has no behavioral changes, hallucinations, or delusions. The patient has been taken antiretroviral therapy since his HIV diagnosis, and his viral load has remained undetectable. Vital signs are normal. MMSE is slightly low. The patient is able to recall 0 out of 3 words after brief distraction and has trouble copying a geometric figure. There are no other focal neurological deficits, and the MRI shows generalized cerebral atrophy with no mass lesions or white matter changes. Which of the following is the most likely cause of this patient's memory impairment? Is it C or A? Now, I said earlier that if the viral load is controlled, if the patient is being treated, it will never be C. And everything else, all the underlying symptoms, shows that this is Alzheimer's disease. Our next topic is dissociative disorders. Now, this is not under neurocognitive disorders. It's its own separate topic. But because this is such a small topic, I'm going to include it here. This is what you talk about when we think of multiple personality disorders. And dissociative identity disorder is also a part of this. This is when your brain separates yourself from remembering things or from events. So the patient will present with amnesia. There will be periods of time in which they don't remember anything. Then personality changes, confusion, and erratic behavior. Dissociative fugue used to be under dissociative amnesia, but it has recently been moved to the outside in DSM-5 because this can be present in all these types. Dissociative fugue is just amnesia when there is a history of sudden unexpected travel. So the person would travel somewhere and would undergo these dissociative disorders. The treatment for these patients is to help them cope with the stress or trauma, and individual psychotherapy must be prescribed. So the cause for dissociative disorders is usually some underlying stress or trauma. We will talk about a dissociative fugue case. A 30-year-old woman is brought to the ER by airport security after she exhibits signs of disorientation and confusion. She kept asking strangers why was she at the airport and asking them her name. Her passport shows that she has traveled from a city far away. Using her passport details, the ER contacts the woman's family, who claims that she has just left from a funeral of her dog, whom she loved very much. So there was a stressful event, and she had a history of recent travel. And after the travel, she has forgotten who she is, where she is, everything. Dissociative amnesia is the inability to recall important personal information, usually after severe trauma or stress. And this may be accompanied by a dissociative fugue. And next, we learn about dissociative identity disorder. Now, a lot of movies love to go into this. This is the multiple personality disorder, which is no longer what we call it. But when there are 2 or more distinct identities or personality states, this is what you call dissociative identity disorder. So a person would wake up in the morning, and then by 12 p.m., okay, let's make it 6 p.m. The person will not remember anything from 6 p.m. till the morning next time. Or the person could wake up on Monday, will not remember anything, and the next time she wakes up, it's already Sunday. She will have no idea what happened during this entire time period. And it is more common in women, especially when there is a history of sexual abuse. And this abuse is usually a prolonged abuse, not just one time. It has been happening for a while. So think of it as if the brain, as a defense mechanism, removes your identity so that you don't remember that. Then in cases of PTSD, depression, substance abuse, borderline personality, this is very common, and you need to know that this is an association. And these patients have lapses in their memory. Now, let's take a look at this case study. A 23-year-old woman is brought to the office by her boyfriend, who is concerned about her intense mood swings and unusual behavior. The patient has rapid mood shifts that lasts a few hours. Although she is typically quiet and reserved, he reports that she can suddenly become enraged without provocation. The patient does not remember these episodes. The patient works as a librarian, and last night her boyfriend found her at the side of the road dressed in a seductive outfit. So basically Bruce Wayne by day, Batman by night. When he called her name, she did not respond to him and just walked away. When he confronted her at home, she denied having been outside and started crying. When she finally started speaking, it was in a childlike voice saying, "Leave me alone." The patient has experienced depression and anxiety since childhood but never received psychiatric evaluation. She was sexually abused from the age of 8 to 10 by her stepfather. She is medically healthy and does not use alcohol or illicit drugs. The patient has many gaps in memory, and her mood is anxious, and she hears voices that she describes as coming from inside her head. Which of the following is the most likely diagnosis? We did not talk about depersonalization disorder, but this is when there are two or more distinct identities or personality states. And think of it like this. Depersonalization is someone who experiences another person's. Think of these sightseers, those fortune tellers. Think of them. They will be telling you something happening in your mother's house as if he's looking over above them. He's watching them at this moment. He will be telling you things. This is what depersonalization disorder is. They feel like they have been detached from their body and is elsewhere. Derealization is simply deja vu and jamais vu. So deja vu is when you are in an unfamiliar environment, you feel like you have been there. You feel that area is familiar. But in jamais vu, in a familiar environment, you find that location to be unfamiliar.